Hi, Dr. Garima here again, and I'm just quickly shooting this video before I dash off to take my son from the nursery, have a pediatrician's appointment for his checkup. So, yeah, it's across the week today. I just opened the question thinking which question would come the next, and it's again a prosto related question. So, yeah, it's a prosto bonanza week. So let's quickly solve this another scenario-based question for the Australian exam. And I guess the September candidates are just waiting for the results to come out. It's already been 2 weeks since the exam. I think another 2 weeks to go before the results come out. But anyways, let's just start solving one more question. Now, a 60-year-old male patient comes to your clinic complaining his lower teeth are loose and painful. Okay. The upper arch is fully edentulous. There's no teeth in the upper arch. The lower anteriors are present, which have a grade 3 mobility. He requested a lower denture. You both agreed on extraction of the mobile teeth and replacement with an immediate denture. Okay, many keywords out here, and a deep understanding of the subject is required. 60-year-old, okay, lower teeth are loosed, and it is decided that the lower anterior teeth which are loose, which are grade 3 mobile, will require a lower denture. The question is not mentioning that the posterior teeth are absent, so you have to assume that they are present. And you also have to assume that they are present because he's asking a replacement with an immediate denture. So if you're going to give an immediate denture on the lower teeth, posterior teeth have to be present. So what is your understanding about immediate denture, and have you given one? So what are immediate dentures? So basically the day one when the patient comes to your clinic and he says I want to extract, say, my lower tooth, you take a scan, okay, or you take an impression. I mean, of late digital scans are so easily available that impression material just doesn't strike your mind. You just take a scan, it's the most easiest thing. But yeah, if you don't, then you will end up taking impression material, and you have to take for mobile teeth an impression material which will not get wedged between the undercuts, or will become so hard that when you try to remove the impression material, the tooth itself is gonna come off, or it's gonna be very painful. So silicone is out of question. You will use alginate, okay? So now what you do is, day one, the patient comes to your clinic and says, I want to remove the tooth. You take an impression and you make a cast. And the teeth that you're removing, you trim that off. And then you make a denture on that cast. And when in the second appointment the patient comes, you extract that teeth and immediately give that denture. So that is called as an immediate denture, so that the patient is walking out of your clinic after extraction with teeth in the mouth, and you ask the patient to wear that immediate denture straight away for 24 hours, the first 24 hours, then remove, clean it, and then start wearing it again. And immediate denture is kind of a temporary thing because the patient doesn't want to be seen without teeth. But what will happen is, because the area where the extraction was done is gonna shrink now because the blood clot has formed and the gums are going to modulate themselves over it, the impression which you had taken before is no longer the same impression the patient is gonna end up with once the extraction site has healed with, right, the surface. So the denture is no longer going to fit very nicely. That's why you would need a replacement of that denture, or you will have to reline that denture and keep on relining that denture until a permanent one is made. So that is an immediate denture. It's a temporary denture, not for a long-term basis. Understood? So you need to understand the concept of an immediate denture to answer this question. So let's get back to this question. What test or procedure will help you in planning process of partial or complete denture for this patient? See, whenever a patient comes to you and says, I want a denture or I want a full complete denture, what is the first thing that you do? You always take an OPG. Why? Because in the mouth, it's edentulous. Okay. Or example, even if the patient had, say, 4 anterior teeth or 4 posterior teeth and the rest are edentulous areas, because there are no teeth, you really don't know what is happening in the bone. So there is no particular test that you can do. I know you can do tests on the remaining teeth, but you don't know what is happening in the bone inside before you actually give something. So you want to make sure that there are no root pieces left behind, there is no foreign body, there is no lesion happening, because you don't want the patient to come back later and say, because you gave the denture, I'm having a pain here. You want to make sure everything is okay before you give the denture, right? So you will first take an OBG. So OBG is the answer. Trans-elimination, I'm not interested because no caries is there. Like I can see if there is caries, then only I'll do that test, because I'm planning for the removable partial denture. If I'm planning for some other procedure, probably trans-elimination comes. But for this particular case, OBG becomes the most important answer. Percussion can be. Vitality of the remaining teeth, yes, that's a right answer too, but that would be a later choice of my test. Full mouth periapical views, OPG would serve the purpose. Periapical views are great when you have teeth. When you don't have teeth, what will my periapical view do? So I rather take an OPG, right? So OPG is the right answer. After that, I would choose vitality. After that, I would choose percussion. And after that, I would choose trans-elimination. And I will never choose full mouth PA for a complete edentulous patient. Now you decided on lower anterior teeth extraction and immediate denture placement. What kind of consent required from the patient here? For any invasive procedure, always a written consent. Verbally, you're going to explain everything, but it's a written consent because you have to document, and the patient has to sign that he's understood what you're doing, he's understood the consequences of it, and you're going to document that. Always a written consent. So, if you decide to give acrylic denture, what is the advantage of acrylic over cobalt chromium? The only one advantage that you have of acrylic over cobalt chromium denture is that you can add additional teeth onto it. Now, for example, in periodontally compromised patients, you gave a cobalt chromium denture and then one tooth fell off. You'll have to repeat the entire procedure and make a new cobalt chromium denture, because like I mentioned in my previous video, you have a major connector, a minor connector, a direct retainer, an indirect retainer. All are very specific and formed according to measurement of each tooth. You just cannot add on thing to it, because you cannot just attach something from outside once a cast partial denture is formed of a metal. But in acrylic, even if it breaks, or you want to add additional tooth, a distal one for example, or a tooth which is in the center of something, you can always trim that acrylic plate and add another by just giving it to the lab. Easy, affordable. That's why, and that is the only advantage of acrylic over cobalt chromium. Of course, price is another advantage, but then it's not so strong. So cobalt chromiums are expensive, but they are more stable and they last longer. But a tooth cannot be added in that. So in this particular scenario, if you feel there are more teeth which are wobbly, and sooner or later, because of the periodontal with the age related stuff, that the tooth is going to go away, then acrylic denture is the denture of choice. Now, yeah. So this question basically I've answered that the advantage of acrylic is can be repaired and teeth can be added on easily. What impression material would you use in order to produce impression for the diagnostic cast construction? So what is diagnostic cast? Is the first cast that you make of the patient. So like I mentioned, it's the world of the scans and nobody takes impressions anymore. But yeah, for diagnostic, it's always alginate. It's very easy to do. It's easy to remove. Zinc oxide eugenol, no, it's not a good material for diagnostic. It's a good material for the final impression in a complete dentulous patient. PVS is silicone. It will become so tight. It will become so tight after it sets that the tooth itself is gonna come out. If it's a grade 3 mobile. Polyether, very expensive, not recommended. Impression plaster, again, it's gonna become so thick and so tight, it's gonna take the tooth out with it. But alginate, it would still be in a rubbery stage, and you can remove it without getting much discomfort to the patient. Now, after immediate denture insertion, what would be the patient expect? He will need a metallic based denture. Nothing. Denture will last for life. No, it's an immediate denture. Denture will help in healing the socket. to a certain extent, okay. He will need a new denture or lining for sure. None of the above. It's option D. See, when you give an immediate denture, it's not the final treatment like I had mentioned, because the extraction socket is gonna heal, it's gonna shrink, and it would no longer fit the denture base. Plus, you have actually not made the denture according to the impression, because you had teeth, you trimmed it off, and approximately you made the denture. So he will definitely need relining and rebasing. So you have to tell the patient that you have to come back and get another denture made. This is not the final denture. So don't come and complain again that after a few weeks that the denture is not fitting. It is not supposed to fit. It's just an immediate temporary replacement of teeth. I hope this is clear, correct? And I really hope the audio in this video is fine, because like I had mentioned, I changed my desktop. I got a new one because my laptop the screen was giving me a lot of problems. Plus it had become terribly slow. Also, yeah, it was like 4 years old. So yeah, now I have two laptops. One is 7-year-old, one is 4-year-old, and now I've got this desktop finally because I have a lot of online works off late and I need a bigger screen. So yeah, and I like this keyboard. It's a little bigger than the laptop ones, you know, so I'm a traditional old school girl. I like the traditional ways. So yeah, anyways, so I'm gonna dash. It's 1 o'clock out here. I have to go, and I hope you enjoy this video. Leave your comments. Always happy to know about it. And yeah, that's it. Have a nice day. Bye bye.